Hi everyone, my name is Dr. Mary Claire Haver, and I am a board certified obstetrician gynecologist practicing medicine in Texas. I am a menopause expert. I'm also certified in culinary medicine, which makes me a nutritionist as well. I'm the creator and founder of the Galveston Diet and my own menopause clinic, Mary Claire Wellness. And I do a lot of teaching and education across all social media platforms on women's health, specifically on menopause. Today, I am coming to you live to talk to you about menopause hormone therapy. This is one of the most common questions that I get, and one of the most misunderstood and confused topics out there in medicine. And so I'm going to do a brief overview of your treatment options for hormone therapy and some talking points for you to discuss with your physician. So if you're just joining me, my name is Dr. Mary Claire Haver. TikTok asked me to reintroduce myself ever so often, and I'm coming to you live to talk about hormone therapy and what your best option might be. So if you're here, remember you can always ask a question in the comments. I tend to not be able to get back with them until the end of the talk, and because I've got a lot of information that I'm going to try to get through. Thank you for all of the interaction, the likes, the comments, the shares. So hormone therapy, what does that mean when we say hormone therapy or hormone replacement therapy, or in the layman's terms, HRT? So HRT stands for hormone replacement therapy. It's meant to give hormones back during the estrogen deficient state associated with perimenopause and menopause. And there are several ways to get this medication into your body. So when we look at, when a doctor or physician, when I talk to another physician or another medical healthcare provider about hormone therapy, in reference to perimenopause or menopause, the main hormone we are talking about is estrogen. Now, in our body, we have three types of estrogen that tend to float around. We have estradiol, which is the number one, very, very bioactive, created in the ovaries, the main estrogen component of our body. There is estriol, which is created in pregnancy. We don't have a whole lot of it outside of being pregnant. And then there's estrone. Estrone is created by, in our peripheral tissues, mainly fat cells, by the aromatization of androgens such as testosterone. So estradiol by far is the most bioactive of these hormones. Estriol really only comes into importance in pregnancy. And estrone is in varying levels depending on how much fat tissue you have, and is not really considered to be that bioactive. You can have high levels of it, but it does not it doesn't cause nearly the same effects as estradiol does. When we are making recommendations for hormone replacement therapy, we are usually talking about estradiol or synthetic versions, which are usually ethinyl estradiol or northendrate, or we are talking about conjugated equine estrogens in the form of what you might know as Premarin. So when we look at what's available to put back in your body for hormone replacement therapy, when we're just talking about estrogen, again, synthetics, estradiol or estrone or estriol, or the conjugated equine estrogens, which is what you would know as Premarin. There is no generic for Premarin. Okay, I tend to avoid it in prescriptions. One, it's usually very, very expensive for the patient. And number two, I have a personal problem with prescribing Premarin because of the way that it is collected and the way that they treat the horses. So Premarin stands for pregnant mare urine, Premarin, and it is considered to be unethical the way that it is produced. So I stay away from Premarin because I have lots of options that work very, very well. Okay, so now we're talking about synthetics. So the vast majority of birth control pills contain synthetic estrogens. Many of us, myself included, were on them for years. They cause no problems. When we're talking about synthetic versus body identical, or the estradiol, okay, They have not been shown to be more or less efficacious or more or less dangerous than the other forms. There's no studies at this point proving that synthetic versus body identical is better or safer. So I just want to lay down those ground rules. I know a lot of you are being told that body identical is the way and they're the only way and they're the best, but there's just not a study actually proving that. So the good news about estradiol is that there are generic versions available for you and can really help to bring the cost down. So if you still have a uterus, okay, so if you were born without a uterus, or which is a genetic condition, or you have had a hysterectomy, you must have some kind of progestin along with your estrogen to protect the lining of the uterus. Now that could take the form of progesterone or a synthetic progestin or a Mirena IUD or another IUD containing progesterone. And so those are your three options. But if you've had a hysterectomy, you really are not considered to need any form of progesterone. It's only an estrogen that is going to be recommended to you. So now we've got estrogen or estrogen plus progesterone. Okay, so these are the two main top. Now, there's different types of estrogen. I've discussed those before. We have the body identical, which is estradiol, and I'm going to go off on a tangent on this in a second when I talk about compounded body identicals. We have the synthetics, which actually work really well, and then we have the Premarin, of which I'm not a fan of prescribing for personal reasons, okay? I'm not trying to get everyone off of Premarin. If you love Premarin, it's working for you, then for God's sakes, just keep going with it, but I don't like it because of ethical reasons. Okay, so how do we get it into your body? Okay, how do we get any medicine in our body? Well, pills are the most popular form. We also have transdermal options, which could include a patch, which could include a gel, which can include a cream. Okay, we have vaginal rings that we can insert in the vagina that have the medications embedded in them in order to absorb into your system. And we also have these new things called pellets, which are inserted under the skin to release the hormones over time. Okay, so if you're just joining me, go ahead, everybody, like this video. If I'm presenting this on TikTok, but I'm going to share it with YouTube and other platforms. Take a minute here to get a pencil and paper to take notes if you feel like you need to. If you are coming in late to this talk, I will have it posted on Facebook and YouTube. And double tap the screen to like the video. So you just tap on my face like this 10 times. This will help make the algorithm do well for me. I'm a 53-year-old mom. It's really hard for me to get much traction on social media. So all the likes and the shares and the comments really help. So I will get to some questions at the end. I see some really good questions coming in. So here is my take on pellets. So Bi-est and Tri-est, which are often found in compounded bioidenticals in the form of pellets, have a combination of estradiol plus either estriol or estrone, okay? I don't know why a woman would want to take a pregnancy estrogen if she's not pregnant. That is not, and it's not really, and the estrone is not bioactive hardly at all. So I just stick to estradiol. That is my preferred method. It's what's been tested. It's what all the trials are done. The compounded formulations are not tested by the FDA. Their labs are not regulated by the FDA. And when the FDA did go and do secret shopper testing on the 10 largest compounding labs that were making pellets, they found a 34% discordance in what they said was in the pellet and what was actually in the pellet. So if you've not been doing well on pellets and you have to keep going and adjust to your dose and doing all this stuff, and it's a different one every time, you can't figure out what's going on, it may be because your pellets don't actually contain what they say they contain, versus something that you pick up at Walgreens, it's a 2% discordance, meaning pretty much what you see is what you get. Okay, so is it covered by insurance? Things that you can drop up at your pharmacy and pick up are usually covered by insurance, okay? Compounded pellets are usually not. That's another reason why I have chosen not to prescribe those or to insert those, because they're not covered by insurance. And I have absolutely wonderful options available to patients that can be covered by their insurance company. Okay, so All right, so we have estrogen or estrogen and progesterone. So of the oral pills, you can do oral estradiol. That is cheap, easy, and body identical, and it is absolutely comes in multiple strengths. And but the caveat of when you go oral versus transdermal, there's one extra risk factor for oral. When we take anything orally, it goes into the gut, right? Gets broken down, absorbed stomach, and then small and large intestine. The portal vein pulls everything from the gut through the liver for processing first whenever we ingest something. And that can increase your clotting factors. So if you are at risk for blood clots or had a history of blood clots, you would never be advised to do an oral estrogen. Transdermal forms, the patches, the gels, and the creams can take the risk of those blood clots down to almost nothing. So if you've been told that you can't take hormone replacement therapy, go back and argue that, hey, you can give me transdermal and it should not increase my risk of clotting. Again, it's up to you to decide if you want to take it or not, but doing a transdermal route is another good option for that. Now, as far as what progesterone to take, there's synthetic progestins, which is what was used in the breast cancer studies, which have been shown to increase breast cancer. And then there's actual body identical, which is just progesterone. There's no good transdermal form of progesterone, of the body identical progesterone. It doesn't absorb very well in the skin, so you have to take oral. So a lot of people will end up on a transdermal patch for estrogen and a pill for their progesterone if they want all body identical. So that's kind of it in a nutshell. I will be having an online webinar where I'm going to go into a lot of detail with slides and courses. And I advise all of you to, if you are ready to arm yourself with information to take to your doctor, to go and advocate for yourself for hormone replacement therapy, the North American Menopause Society has just released their 2022 statement on hormone replacement therapy. And in a nutshell, they are saying that for almost all women under the age of 60 without an absolute contraindication, the benefits far outweigh the risks of being on hormone replacement therapy. So all the gobbly bullshit about breast cancer and all that has gone out the window, and a woman is much more likely to have a healthy, productive life and be absolutely more of a well woman if she takes hormone replacement therapy than if she doesn't. Oh, sound issues, sorry. Okay, is that better? Okay, so let me get to some questions. So go ahead and post your questions down below, and everybody double tap the screen again. Thank you so much. Go ahead and interact and post some questions and better. Okay, yeah, I had it on my computer and the fan kicked on and that hurts. Okay, so let me go back to the top and I will go ahead and answer some questions. So today, if you don't know me, hi, I'm Dr. Mary Claire Haver. Please follow me if you haven't followed me before. I love talking about hormone replacement therapy and estrogen, progesterone, and all the good things. So glad you found me. Thank you. Can Mirena help with menopause symptoms? Yes and no. If your perimenopause symptoms are related to heavy bleeding or cramping, a Mirena can be helpful, but it's a very minimal dose of progesterone, so it's not considered to be enough to be an effective treatment for the symptoms of perimenopause. It does not do anything for heart disease or colon cancer or bone density or any of the things that are so helpful that we get from taking estrogen. Oh, thank you for following. Everybody, thank you so much for following. Please follow me. You are a dumbass. I don't know if I'm a dumbass, actually. Well, you may think so, but so I have a bachelor's degree in geology from the University of Louisiana, and then I worked as a geologist for 2 years. I had a change of heart and applied to medical school. I went to medical school from 1994 to 1998. I graduated Alpha Omega Alpha at the top of my class, and then got my top choice of OB-GYN residency at the University of Texas. Where I graduated with multiple awards. I went back to school in 2018 and got my nutrition degree in what's called culinary medicine. So it's medical nutrition, so that I could help my patients navigate the world of nutrition better through their perimenopause. So it just means I have a lot of school and a lot of degrees. Doesn't necessarily make me smart. I agree. So what hormone is imperative in assisting in hair loss? That's a great question. There are multiple forms of hair loss. Multiple reasons why we lose hair. I have a huge YouTube video about this that's very, very popular. If you go to my YouTube channel, just type in Mary Claire Haver and you'll see I have one on hair loss where I go through lots of reasons why women our age lose hair, and I go through different treatment options to at least arm yourself with information that you can take to your dermatologist but a lot of people, when we experience the rising androgen levels associated with perimenopause, we start having kind of male pattern hair loss, especially, in certain areas. Okay, you're perimenopausal. Can you talk about why your skin is so itchy and how you can make it better? Great question. Sebum production dramatically decreases. So that is our natural oil glands naturally decrease with estrogen deficiency syndrome. The dermatologists call it EDS, or estrogen deficient syndrome, or estrogen deficient skin. So when our oil glands kind of stop producing as much oil, our skin dries out. And so the dermatologists tell us we have to be, estrogen can help with that, but it's usually not enough. We also lose collagen. About 30% of our collagen production, level of collagen in our skin will decrease in those first 3 years of menopause. And so what you can do for the dry, itchy skin is emollients. And so, every time you get out of the shower, getting a very thick, like Nivea or CeraVe, really nice moisturizer emollient to put on top of skin. Some people even will layer a layer of Aquaphor or something on top of that just to kind of seal it in, because this dry skin is real and it can be so dry it can cause like itchy in weird places. My back, the middle of my back's always itchy. People complain about crazy itchy ears and itchy skin. So really, 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 you cannot treat your skin the same way that you did before menopause, or you're just going to suffer. Hey Blake, how you doing, sweetie? What about bioidentical hormones? You've been hearing a lot about them. So I like bioidentical hormones, but bioidentical is really a marketing term, not a medical term. So body identical just means estradiol and progesterone, the things that our ovaries made naturally. And they, a lot of doctors are pushing these certain forms, especially pellets, and they're not offering their patients anything else. And so they're personally profiting off of the sale of these pellets. They buy them wholesale from a supplier and then they insert them, and that's how they make their money. I'm not knocking a physician for trying to make a living. I do that myself. However, my job as a physician is not to peddle one form of hormone replacement therapy. It's to let you know what all of your options are. And that you and me together make a decision as to what we feel like is the best based on cost, based on availability, based on risk factors. Every form has kind of a unique profile on what makes it better or worse, et cetera. And it really depends on, it's a very intense discussion with a patient. And so I get nervous when a physician is only offering a pellet and that's all you get. And they're very expensive. You can get hormone replacement therapy for $20 a month with your, out of pocket. Okay. That's not even with insurance, out of pocket. So, body identical is fine, but if someone's only offering you some cream or pellet and not talking to you about any other option, you probably should find someone else who's going to give you a broader range of opportunities. Are over-the-counter bioestrogen creams effective at all? No, they've never been shown to be effective at all. You need a prescription for it to be effective. So I know a lot of Amazon, you can find these hacks of people just doing stuff over the counter. These are not considered, especially the progesterone creams. No progesterone cream is effective, none. And so they're not absorbed well through the skin, so they're basically considered to be. All right, your kinesiologist said I need to seek out the New Jersey diet. I don't know what the New Jersey diet is. No idea. I created the Galveston diet, so I don't look at other diets. I just stay in my lane. Are hormones bad for smokers? You're nervous to take them. So remember, we go on hormone replacement therapy to make our health better, to make our lives better. And blood clots you are at much increased risk of blood clots because you smoke. And so we will not give you a birth control pill over the age of 35 if you're a smoker, anything with estrogen, because of the risk of blood clots, increasing your risk of blood clot. So if you're thinking about going on hormones to improve your health, probably the most effective thing you can do is seek out some help to stop smoking first. And then it really opens up your opportunities for hormone replacement therapy. You've changed my life. Thank you. Oh, you're so welcome. I'm just here to educate. I love doing this. The feedback I get from you guys is everything for me. Taking norethindrone for perimenopause. I'm a huge fan. I love that. Thoughts on the combi patch? I'll show you mine. Right there. See it? That's my combi patch. I'm a fan. Why? Why did myself and my nurse practitioner together decide that combi patch was the right thing for me? One, I wanted transdermal because I wanted to decrease my risk of blood clots. They don't run in my family. I don't have any genetic risk that we know of, but I thought oral versus transdermal. And two, I'm kind of forgetful and I don't remember to do things every day, not every day. And I was nervous that remembering to take a birth control pill every day would I could barely remember to take my birth control pills back in the day, and I knew that this would be an issue. So I thought, gosh, a patch would just be easier for me, and it had the estrogen and the progestin in it together. So the estrogen is body identical, but the progestin is not. I was like, I'll take my risk. It's easy. So I write the date with a Sharpie. You may have seen it on my patch, so I know what day I have to change it because I am so forgetful. And then I just apply it under my underpants. So I'm a big fan and I like it. And that's why I picked it. You did not know the origin of Premarin. Yeah, it's a pretty sad origin. So how do you improve a short cycle? Can you give me more information? I'm not sure exactly what you mean by that. Sammy the Cat just became a top 1 viewer. That's back. Okay, I talked about combi patch. Can you have an IUD and do hormone replacement therapy? Yes, absolutely. Especially if it's a Mirena, you can do a Mirena and oral and estrogen together. That is considered to be adequate progesterone to protect the lining of your uterus. Blakey, text the girls. They miss you too, baby. Catherine was just talking about you the other day and how much she loves talking to you on the phone. Sorry, this is my friend's daughter. Your partner just got the coil and really likes it. So the coil is a non-progesterone containing intrauterine device. The coil has copper in it. It's a great form of contraception, but it does not have progesterone in it, which some people find is something that they want. And it's a great form of contraception. It lasts for up to 10 years. Hello, any tips for PCOS? Remember that polycystic ovarian syndrome is a disease of insulin resistance, not your ovaries. Your ovaries are just doing what your body is telling them to do. And some of the top things you can do to improve insulin resistance are cardiovascular exercise, move your body on a regular basis in some way that makes you happy, at least 30 minutes, 5 days a week. Number 2, watch your added sugar intakes. Added sugars are the sugars added in cooking and processing, not fruits and veggies, keeping those less than 25 grams per day. And number 3, making sure in your diet you are getting at least 25 grams of fiber per day. Those 3 things nutritionally can go a long way to help with PCOS. Estradiol is what you take in the Dottie patch. Yeah, that's another great form of estrogen. You are trying to get pregnant for a while. What test should you ask the doctor to do? You should probably see a specialist. This is their area of expertise. So, and be very, very specific about your symptoms. Like go in with a cycle, go in with a diary of what your periods are like. Has your partner ever gotten anyone pregnant before? Have you ever been pregnant before? There's lots of reasons why someone may not be able to get pregnant. And so remember, to get pregnant, you need an egg, you need a sperm, and then you need a place to hook up. And usually it's something wrong with one of those 3. Okay, so the sperm is not able to get to where it needs to go, or they're not making the right kind of sperm, or you're not ovulating, or, so there's multiple reasons, but those are kind of the top 3. So those are the top 3 things that a doctor is going to check. Who should get hormone replacement therapy? What qualifies a woman? Being a woman. The 2022 North American Menopause Society statement just came out literally yesterday or day before. And it is saying categorically, without an absolute contraindication, a woman is better off on hormone replacement therapy for multiple reasons, multiple organ systems. Remember, the symptomatology of perimenopause and menopause is legion, and we're just recognizing it. Finally, we can stop telling a woman she's crazy. Finally, we can stop dismissing her symptoms and give her, actual treatment for this. And starting the earlier, the better. So qualifies a woman for hormone replacement therapy for her estrogen deficiency syndrome is having ovaries. Okay, everybody's qualified unless you have an absolute contraindication. just join. What if you can't take estrogen like meds? Why not? Because there's a lot of misconception over who can take them and who cannot. And there's just a lot of stuff that gets propagated that really has no basis in the medical literature whatsoever. Let's see. I'm reading the questions. Is Bisolvi, Bisolvi a decent birth control? Yep. Absolutely. Thank you for the roses. Okay, so if you're just joining me, TikTok is asking me to, I am Dr. Mary Claire Haver. I am a board certified obstetrician gynecologist, and I'm talking about hormone replacement therapy and the different types and how to get them into your body and body identical versus non-body identical and safety. So go ahead and put your questions down in the comments. If you missed the beginning of this talk, I will have it posted on YouTube, on my YouTube channel, and on Instagram and on Facebook, so you can find it there. You have a hysterectomy and no ovaries. You are probably a candidate. Talk to your doctor about hormone replacement therapy. Is progesterone, this is a great question, is progesterone needed if you've had an ablation? Your doctor said you don't need it. That is absolutely not true. You may still have tissue that is viable there. You absolutely need progesterone. That is not a statement that a physician should be telling you, and I would find a new physician right away. Thank you for this. Oh, and thank you for following, liking, sharing, and interacting. I really appreciate it. And we have 10,000 likes. So everybody tap my face. So take your finger and tap my face like this 10 times. This helps to drive the algorithm to keep me relevant on this platform. Why is hormone replacement therapy scary for most? The propagation of what happened from the Women's Health Initiative study of all the misinformation that was spread, that erupted in my own training, in my own residency, OB-GYN residency, and we were terrified. Turns out that study's almost been completely debunked. All of the risks have been completely reworked, and we have a whole generation of women who have suffered needlessly through perimenopause and menopause, and a whole generation of physicians who've just stopped learning and haven't kept up with the latest literature and are just refusing to even consider to do hormone replacement therapy. But I have good news for you. I have on my website a list of menopause-friendly providers. I mean, even if you choose not to take hormone replacement therapy, that's your choice, but you deserve a conversation. You deserve everything I'm telling you today, the risks, the benefits, looking at your individual history, your risk factors, and determining, is this something you're willing to do? Because of the multitude of health benefits that could be coming your way. So it's simply scary because it's a boogeyman's tale, and there's absolutely not based in hardly any fact whatsoever, and it's been completely debunked. It's kind of like the autism scare with vaccines, with kids. I mean, it just got propagated. A few famous people got involved. It got spread over the internet, and women have suffered absolutely needlessly because of it. So do you have to wait until your blood work shows? No, that is another fallacy that is propagated in the medical institution. Like, we can't do anything till you haven't had a period for a year. There's no way to treat you. That is not true. You can start perimenopause, absolutely, treatment as early as you want, okay? I start HRT treatment in people's late 30s and 40s if they need it. DHEA is not considered to be hormone replacement therapy, so I'm not going to discuss it today. I've never prescribed DHEA in my life. It's not part of gynecology. That should only be really handled by an endocrinologist, at least in my world. Your mom has Alzheimer's and took HRT. Should I not take it if you're worried about it? Actually, the latest studies are showing that if you start hormone replacement therapy in early menopause, your risk of developing Alzheimer's and dementia is lower. If you start later, once the symptoms have already started, it can actually make it worse. So it's all about timing for cardiovascular disease and for neurodegenerative disease. Start early, very early. The benefits are there, but if you start too late, you may make it worse. Let's see. I'm reading the questions, guys. Hang on. So cancer isn't linked to hormone replacement therapy. Okay, so the estrogen alone, there's no cancer risk increase for breast cancer. Estrogen and progesterone, there is a very slight increased risk when taken longer than 7 years. Okay, that's it. It's about the same as being obese. It's the same as other medications, and nobody's talking about those. Okay, It is about 1 in 1,000 women. Okay, it's not a dramatic increase in risk. And the multitude of health benefits that you will get. Also, the mortality rate for women on HRT from deaths from cancer is lower than women who are not on HRT. Estrogen is protective against almost every cancer. Truth. Documented, tested, truth. Okay. Let's see. I'm reading through the questions, guys. Hang on. Y'all are really piling in. I love it. I love it. Let's see. What would stop a woman from taking HRT? Absolute contraindications, which you need to discuss with your physician. Active liver disease. Okay. Active liver disease, active heart disease, like active, and certain breast cancer risks. Okay. Clotting issues, mom couldn't take birth control. Can you do HRT? Again, that's way too complicated of an answer. Here's the thing, guys. I cannot give you personalized medical information. I can just give you general information. That would constitute a doctor-patient relationship and would fall outside of my ability to practice medicine in the state of Texas. So I can only give general answers. I cannot tell you if you can or cannot take it. So, but yeah, you are less likely to die from cancer if you take hormone replacement therapy. Read the 2022 North American Menopause Statement. There's also, this has been published in 2 other major medical journals. Okay. You've been in menopause for 5 years, but no symptoms, just rapid weight gain. Do you need hormones? I would take them. I would absolutely take them. We know that women who are on HRT have less visceral fat deposition and less belly fat gain, less body composition change than women who don't. Let's see. How long does it take for HRT to be fully working? So for most women to notice the real big symptoms like the hot flashes, the night sweats, and the sleep, it takes about a month on therapy to notice the difference. 7 months, no cycle, then a sudden cycle normal. Probably, however, that's kind of a long time. I would go see your doctor for evaluation. Thoughts on the mini pill to help in perimenopause? Labs were normal. So mini pill is a progesterone only pill. So it will do some good, but most patients will do better on a combined contraceptive because you have that extra estrogen to help level you out through the transition through perimenopause. But it's better than nothing, especially if you can't take estrogen for some reason. How do you get rid of hormonal acne as an adult? You have PCOS and no diet has worked. Go look at the Galveston diet. I'm telling you, we have thousands of PCOS sisters in our following, and they are doing fantastically well. So it's definitely something you should consider and look into. You just started low estrogen, yay, to help during perimenopause. That's awesome. So grateful for you. Thank you so much. Let's see, got that one. DHEA is not hormone replacement therapy. It has no place in OB-GYN. I've never prescribed it. You'd have to see a reproductive endocrinologist to be who's familiar with it, but that is not something that I've ever prescribed in my life. Let's see. I'm reading the questions. Hang on. Okay, I got that one. You had okay. Let's see. Had an ablation, you're 65, you hate that you grew a beard. Bless your heart. Please help. You're on a 1 milligram estrogen patch, 3 months, and it's not helping. What do? You need higher dose. So what was it trying to help? What was it trying to help? Okay, so I am going to run through the options again for you. So when we're talking about hormone replacement therapy, we are talking about estrogen or estrogen and progesterone. We're not talking about DHEA. We're not talking about testosterone. Those are not considered to be treatments for menopause, okay? Hormone replacement therapy is estrogen and or estrogen and progesterone. So there are 3 types of estrogen, okay? There is synthetic, which is what is in most birth control pills in the form of norethindrone or ethinyl estradiol. Okay, made in a lab, works great in your body. The second is estradiol. This is what you guys in the lay would call body identical. We never say body identical in medicine to each other. That's not a word. That's a marketing term, okay? We call it by its chemical name, estradiol. Now, some of the compounding pharmacies with the pellets are doing this biest and triest. So our bodies make 3 types of estrogen: estradiol, estrone, and estriol. Estrone is what is converted in the periphery and the fat cells. You take an androgen, you run it through this chemical process, and it creates estrone. Estrone is not very bioavailable. Like if you take a pound of estradiol and a pound of estrone, the estradiol is going to do 1,000 more things than the estrone. Okay, it's not as bioavailable. Estriol is what we make in pregnancy. It's made in the placenta. So I don't know why a woman would want to take a fat storage hormone or a pregnancy hormone when she's menopausal. That is not anything I was ever taught to do. I simply prescribe estradiol, the end. The third kind is called Premarin. Who knows what Premarin stands for? Pregnant mare urine. Okay. Pregnant mares pee out a lot of estrogen, and so they conjugate it, and we're able to extract it and conjugate it and give it to humans, and it worked great. I don't love it because it was what was used in the WHI studies, and I think there's an ethical issue with how they collect the urine with the poor pregnant mares. It's like inhuman. It's like not ethical. So for that reason, and there's no generic, it's expensive as crap, so I don't prescribe it, okay? I usually just stick to the synthetic or the estradiol. Usually for postmenopausal, estradiol, that's it. Okay. And I'll do an FDA approved version. Now, how do you get the estrogen in your body? You can do oral, you can do a patch, you can do a ring, you can do a pill, you can do a gel. From a efficacy standpoint, they are all the same. Okay. Don't be lulled into thinking that a pellet or a pill or a patch or whatever is any better. No study is showing that one is more efficacious than the other. Some may be a lot more expensive. Now, oral carries a slight increased risk of blood clots that the transdermal methods do not. Transmucosal and transdermal. Okay. If you need a progestin, there is body identical, which is progesterone, or the synthetics. So and I go through all of this with my patients when they come in, and we look at cost, we look at risk factors, we look at, their lifestyles, what's going to work for them. So, and we go from there. This is all different than vaginal estrogen preparations, which are meant to treat recurrent UTIs or atrophic vaginitis. Okay. All right. So when is it too late to start HRT? Never. We just, there's this arbitrary 65, but there's no data to show that it's not safe to be on HRT at 65. It's more efficacious to be on it earlier, but I'm not getting off. There's no data with my history and my risk factors. There's nothing that says I need to get off at any age. So I'm going to stay on. So, however, if you have certain medical conditions, you should not start HRT in your 60s. One is going to be Alzheimer's and dementia. If you have active disease, if you have active liver disease, you have active heart disease. But again, you need to discuss this with your physician. I am just here to arm you with talking points so that you have a better a way to arm yourself with information and to advocate for yourself in the physician's office. Let's see. 37 years old, full hysterectomy due to endometriosis of both ovaries, PCOS. Request information on hormone replacement therapy. Absolutely. Doctor suggested a monthly HRT shot after hysterectomy. Thoughts? I do not know what you're talking about. I do not know what that monthly shot is, so I don't know what that is. That's scary to me because I've never heard of a monthly HRT shot. There's no monthly estrogen shot anymore. Not on the market. Great question. How do you know when to take estrogen versus estrogen and progesterone? Do you have a uterus? If you have a uterus, you must have progesterone in some form. Oral, transdermal, or progestin-containing IUD. That's it. You have a uterus, you need progestin, oral, transdermal, a patch, or a IUD with progesterone in it. If you don't have a uterus for whatever reason, you don't need it. That's it. The end. Okay, everybody. Okay, let me do a few more questions. You're on a patch. My new doctor took testosterone cream away. He said I wouldn't even notice a difference. I don't know if that's true. There's some pretty good studies that are showing that it can be helpful with libido. But it hasn't been shown consistently to help with much else. So I think that's kind of mean. If you have noticed a change in your libido and it's now dipped since he took the testosterone away, you should ask for it back. Let's see. The best way to approach your doctor about this for the first time, 45. One, you should find a menopause-friendly provider. Not every OB-GYN is the same. Some are great at delivering babies, some are great surgeons, but most are not great at menopause. It's not their fault. They're not bad people. They just weren't taught a lot and they haven't kept up with the readings. So I, on my website, have a list. So if you go up here to this Dr. Mary Claire, click on that link. It will take you to my TikTok page. At the top is a link in bio. And if you're watching this on Instagram, link in bio there, you will see doctor referrals. So these are about 900 physicians that have identified as menopause friendly or have had testimonials written up by my followers. I have millions of followers across platforms, and I asked them, I crowdsourced great OB-GYN providers that were menopause friendly. So I have 900 and they're listed by state and city. So hopefully there's one near you. So I just wouldn't really gamble on just your regular schmo gynecologist, because turns out they may not be that menopause friendly. So let's see. Pellet for low testosterone. Nope. Results seem variable. Low testosterone is not a diagnosis in women. That is not a recognized diagnosis in the OB-GYN literature. We all have low testosterone. 100% of women have low testosterone unless you have a tumor or PCOS. So that's not a thing. We can use testosterone supplementation to help with libido in perimenopause and menopause. But outside of that, we don't have a lot of studies to support its widespread use in women. They are mean about it. Yeah, a lot are mean about it. So how long can you take HRT? Years. The North American Menopause Society just redid their statement, and it's pretty freaking awesome. So at least 10 years, if not longer. How concerning is low TDHA, elevated prolactin in a 17-year-old? Girl, I don't know. You need to see an endocrinologist stat. That is not anything a run-of-the-mill OB-GYN at 17 should be dealing with. That is something a pediatric endocrinologist should be all over this like white on rice. You should not. That is a big deal. Gabapentin can help with hot flashes, yes. So if your doctor, but the number one most effective treatment for hot flashes is estradiol, okay? Absolutely estrogen. We only recommend gabapentin if you cannot take estrogen. That's it. It does not work that well. It works okay. Estrogen will work almost 100% of the time. Chance of weight gain on estradiol? Very little outside of placebo. Actually, most of my patients on estradiol experience a decrease in their hip waist circumference, like their visceral fat level goes down. It's pretty amazing to watch that happen for them because we do measure it here. Let's see. All right. So if you're just joining me, everybody double tap the screen to like the video and please follow me. I love talking about all things menopause. Reasons not to take estrogen, because your doctor's an asshole and won't prescribe it to you. But contraindications are active liver disease, active heart disease, active breast cancer, and or a history of breast cancer that was estrogen receptor positive. And active Alzheimer's and dementia. Like if you're over 60 with active Alzheimer's and dementia, you should not be taking estrogen. So hypertension is not a contraindication to, and blood clots, not necessarily, because we have transdermal options which do not increase your clotting factors. So migraine specialist said no estrogen for you. They are confusing the recommendations for birth control pills with the recommendations for hormone replacement therapy. Those are very, very different. Very, very different. Can HRT help with melasma? No, the only thing that's going to help with melasma is bleaching and sunscreen. Let's see. Thank you for all the likes, you guys. Awesome, awesome, awesome. Okay, so the GLP-1 agonists, I've done some research on that. It's a temporary fix. If you haven't maximized your nutrition, I would not consider those type of medications unless you have maximized your nutrition. What people want to do is do nothing different with their nutrition and take these medications, which can have horrific side effects, without fixing the problem, because most people with the right nutrition will never need the GLP-1 agonist, the vast majority of people. Let's see. Complete hysterectomy. Your doctor says you need it because of autoimmune problems and dryness. I agree. Yeah, that sounds completely reasonable to me. Okay, so everybody, thank you for double tapping and liking and all these questions. Okay, what are healthy ranges of estradiol? We do not have therapeutic ranges. So if your doctor is making you come back for all these blood levels of estradiol, stop going to that doctor. There's never been, we treat based on symptoms. We don't, of course we all process estrogen and stuff differently, but there's no therapeutic range. There's no therapeutic range. So until NAMS or some other governing body, they're spending a lot of money on something that's not really helpful. Okay. What does HRT help with? HRT decreases your all-cause mortality. HRT decreases your risk of dying from heart disease. HRT decreases your risk of dying from all cancers. HRT decreases your risk of osteoporotic fractures. HRT decreases your risk of type 2 diabetes. HRT decreases your risk of accumulation of visceral fat. HRT decreases your risk of chronic disease. All proven. All real stuff. So, actually, this will be a fun TikTok to make. All right, everybody. I am in clinic. I've got to get ready for the next patient. I'm reading the questions. Okay, and everybody like and follow and share. I am going to make a TikTok about what HRT can do.